Hi everyone, welcome to the series on labs to clinics for microbiology. I welcome you all to this session of labs to clinic. Those of you who have joined, please come and say hi in the chat box. So we have a rather important and interesting case for you today, that is of an undiagnosable fever. Now you must have all heard about the fever of unknown origin, right? And the application of that fever of unknown origin is what we are going to discuss today. Now this is a very, very important topic from the perspective that most of the times we get patients of fever and we are not able to diagnose, right? So how do we approach such patients? The takeaway from today's lecture is not to reach to a diagnosis, okay? What is the ultimate aim is, if we have somebody whose fever's cause we are not able to, find out, what should be our approach going forward? All right. So that is what we are going to discuss, a rather interesting and mysterious case today. And with this mystery case, what you are going to achieve is, how do you approach a case of SEO and what test to order and when? This is primarily of importance when we talk about microbiology. Your takeaway from all microbiology lectures should be that when you're a clinician, when you're dealing with patients, what tests you're supposed to order. Okay, what investigations you want to do in your patients, in which order you want to conduct those investigations, when do you want to order investigations, what are the prerequisites which are necessary so that the best results can come out from the lab results. Okay, and they aid you. Thank you so much, Bhumi. Very nice to see. Of course, I always try to make you learn things, right? All right, so let's continue. So when to order these tests so that the lab tests, they don't confuse you, they help and aid you in coming to a diagnosis and reaching a diagnosis. How to interpret the lab results, this is extremely important, because in my practice the most common thing that I have noticed is that a lab report comes out and most of the times we don't know how to interpret it for our patient. Of course, we can read a positive and a negative. Well, a positive and a negative lab report is only an indices of a positive or negative test result. That does not always apply to the fact that our patient might be suffering from the disease which the test is indicating, right? So interpretation of these lab tests is very, very important. So in across these case series, the cases that I've been discussing, that is what we are aiming to order. That is what we are aiming to achieve, right? That we have these lab results, we have these tests. How do we interpret and reach the diagnosis which we might be missing? How to microbiology guides medicine and not confuses it? We have already seen this aspect. Now, learning objectives, by the end of this lecture, you should be able to define fever of unknown origin, the Harrison definition which is there, right? You should be able to approach a patient with prolonged fever. You should decide what test to order, interpret microbiology reports and understand the treatment principles, all right? How are you going to go ahead with the treatment of this patient? So let's start. It's a 32-year-old male patient who had a fever for 5 weeks. Daily episodes were coming. Temperature was 101 to 102 degree Fahrenheit. So you can say it's a high grade fever. It's a high grade fever. Partial relief with antipyretics, meaning that it is resolving every time the patient is taking an antipyretic. This is a very important history because for most viral illnesses, especially the seasonal ones, the fever usually is of the non-remitting type. It does not become normal. Okay, chalo. So daily episodes of fever since 5 weeks, high grade fever, which partial, relief with antibiotics. What does that mean? Hi, Sonu. That means that every time the patient is taking PCM, it's subsiding, then again it comes back, again the patient is taking PCM. What is important whenever we try to take a fever history is, we need to find out what is the pattern of fever. We always tell you 2-3 important histories associated with fever is always, number 1, what is the pattern of fever, and number 2, if any associated symptoms are there or not. We asked, when the patient told that there is an evening rise, there is associated chills, however there are no rigors. So can you tell me, those of you watching, can you tell me in the chat box, what are your pointers from this? If there is an evening rise and associated chills but no rigors. So no rigors is a pointer towards Which infectious agent? So, we have a saying in microbiology, and it is kind of an old saying, but it still is quite relevant in today's day and age, that every fever is a malaria unless proven otherwise. Right? I mean, so of course, whenever in a endemic zones in a country like India, where you have to think about infections first before you think about other things, malaria is a super important cause of fever. Classically presents with chills and rigors. Yes, very nice, crazy. Your name is crazy, so I'm calling you crazy. No rigors. Associated chills and evening rise. Does it give you a hint towards some important etiology of fever, which you keep reading? However, we keep telling you that evening rise of temperature may or may not be associated with with this disease, but every time you think of India, you think of this infectious disease, right? So TB. Okay, let's see. So up till now, I know that it's a high grade fever. It's been there for 5 weeks, and it's a evening rise of temperature is what is happening. Okay. Associated complaints, of course, we have to ask each and every patient. So patient is saying that he has lost 4 kgs of weight till the time, from the time that he had fever. Yes, Sunny, TB, you are correct, right? So since the time that he got the fever, since the past 5 weeks, he's lost 4 kgs of weight. He has associated fatigue, mild headache, not associated with cough, urinary symptoms or abdominal pain. So there is no related associated organ system specific symptomatology. Every time you have a fever, you can think of a UTI, you can think of any systemic involvement, or you can think of a overall bloodstream infection. From this cough, upper respiratory tract, URTI has been ruled out. Not ruled out, but yeah, we don't want to go into that direction. Good evening, Kalyan. Urinary symptoms are not there, no burning micturition, no increased frequency of urination or urgency, etc. is there. So you can now not go into the direction of a UTI. Because a 32-year-old male having fever, you should think of UTI. Then no abdominal pain, then probably a very, very important cause such as typhoid or enteric fever, sometimes associated with abdominal pain, or there might be any focal sources of infection. So that फिर भी समझ में आएगा. Great, Tejas, that's very nice, right? No abdominal pain. So this is kind of pointing me that probably this has something to do with the systemic involvement, overall systemic involvement. Good evening, Yash, right? There is no history of diabetes. So we always tell you that in history taking, you first talk about the presenting complaint. The presenting complaint is fever. You try to elicit as much information about fever as possible and as much associated symptoms as possible. Then you also need to think about past history, family history, etc. So diabetes is not there, HIV is not there, steroid or immunosuppression is not there. So what is this telling me? That the fever that the patient has, he's a immunocompetent patient. He's not an immunocompromised patient. There is no history of recent travel, because recent travel always tells you about the viral infections of the zoonotic origin, tick bite fevers, sandfly bites, travelers diarrheas and all of that. All of that has been removed from here. There is no known TB contact. Since you are in India, of course, you have to try to elicit as much in-depth history about TB as possible. Good evening, NEET student. Yes. So all of this we know. So up till now, what do we know? It's a chronic type of a fever since 5 weeks. The patient is immunocompetent. There is no immunocompromised history. There is no specific organ system involvement in this patient. So it is kind of a systemic, generalized, chronic kind of a fever that I'm getting. Of course, you're going to examine the patient, and the patient's vitals are stable, meaning the BP, pulse rate, respiratory rate are all within normal limits. There is no tachycardia, there is no bradycardia, there is no fluctuations in the blood pressure. There is no rash associated. This is supremely important, because the first lecture of this series, when we discussed fever with rash, every time you have a patient of fever, eliciting the history of rash becomes supremely important, because every time you have a rash, we go into the complete separate spectrum of fever, which is the fever with rash etiology. Now, depending upon the type of rash, depending upon the age of the patient, depending upon the immune status of the patient, it's a whole different lecture, which we have already covered. The first lecture in the series of labs to clinics. There is no lymphadenopathy, right? So it is telling me that no lymph node enlargement is there nearby the places. So again, no specific organ system involvement. There is, however, mild splenomegaly on touch. So basically, when the abdominal palpation was done on the patient, mild spleen enlargement was Seen. Okay, this is telling me something. No focal signs means no focal neurological deficits, no focal other local signs of infection or inflammation in other parts of the body. So up till now, what all information do I have? That this is a chronic fever. There is weight loss, there is splenomegaly, and there is no localization of symptoms. These are generalized symptoms. You can't say that there is any localized symptoms such as burning micturition or like that. Yes. Okay. Based on this, what is this telling me right now? 5 weeks of fever. Now, baseline investigations are done for each and every patient. So, we have done a CBC, and on the CBC, we found out that the hemoglobin was 10.8. Normal WBCs, normal platelets, raised ESR and raised CRP. So, I know that more or less CBC is normal in the patient. However, ESR and CRP. What is CRP and ESR? Erythrocyte sedimentation rate and CRP. Shivam, okay, no MBBS will not be hard for you. Just keep preparing, right? These are raised. So what are these? These are markers of infection and inflammation for me. Anyways, the history is 5 weeks old. CRP and ESR is raised. Okay, then I can think that some kind of a chronic infection is definitely happening in my patient. CRP is raised means some inflammation is there. ESR is raised means some chronic infection might be present, right? WBC is normal. If normal WBC is there, then this is probably telling me that acute pyrogenic infection is not there, meaning acute bacterial infection, acute pus forming infections are not there in this patient, right? Yes, you're right, C-reactive protein. When they did a peripheral smear, what do we do a peripheral smear for? Malarial parasite. So they said that any malarial or filarial and parasites were negative. So we do it for malarial parasite and they said that this was negative. Then of course dengue you will do in a country like India, in endemic states, especially like Delhi, wherever you get a fever. Dengue NS1 antigen, which is the first test that you do, plus now since it's a 5-week history, so you also want to do some IgM. IgM both have turned out to be negative. Rules out dengue. Then of course in a workup of a fever patient, you will do the normal blood markers of infection and inflammation which will point you towards either a bacterial, viral, fungal etiology, chronic etiology, acute etiology. Then you will do two most important causes of fever, which is malaria and dengue. Then you're going to do a chest x-ray because you want to find out the systemic involvement inside the patient. If the chest x-ray is normal, there is no specific findings in the chest x-ray of the patient. Also, there was no associated cough, etc. So, now you know that, okay, no respiratory involvement is there. Why do we do chest x-ray in the absence of a respiratory symptomatology? Because pneumonias, especially the atypical pneumonias, they can also present with simple fevers inside the patients, right? The atypical bacteria such as Mycoplasma chlamydia, they can present with fevers. Patient comes walking into your OPD. So, they are called as walking talking pneumonias. So, when you do a chest x-ray, you see, oh my God, there is a pneumonia in the patient, but the symptomatology is quite normal. Urine routine is done and that is also normal. So now based on the symptomatology, based on the investigations, you have ruled out a UTI, you have ruled out a URTI, upper respiratory tract infection also, right? Now this is kind of telling me that this is a chronic involvement and some systemic involvement of a chronic infection is there, right? Every time you have a systemic involvement, focal involvement has been ruled out. Fever has been present for the past 5 weeks. You have to now think about fever of unknown origin. Because the patient for the past 5 weeks has been undergoing all these investigations and everything is coming out to be negative. At this point, you are not able to think what is the cause of fever. All the most common causes of fever have been ruled out. So now you will put it under the category of fever of unknown origin. Why? Because all the criteria of the fever of unknown origin is what is meeting. Now, this is straight out of Harrison, the old classification and the most widely accepted classification even till today is this. This is a classical FUO or a classical PUO, whatever the books might say. I think now Pyrexia of Unknown Origin has been totally replaced with the term fever of unknown origin, the term FUO, right? there is more than 38.3 degrees Celsius or more than 101 degrees Fahrenheit of temperature in the patient. Does this qualify in our patient? Yes, it qualifies. He was having 101 to 102 degree fever. The duration is more than 3 weeks. Yes, that also qualifies. The patient has fevers in the past 5 weeks, 1 month, 1 week. No diagnosis after 1 week of evaluation. Now, you know, 1 week of intelligent inpatient evaluation. So basically the patient must have been admitted inpatient in house in a hospital, and 1 week you have had intelligent investigations. What is the meaning of intelligent investigations? We will see in just a little bit. So this is the most widely accepted definition of a classical FUO. Now newer classification is also coming. They ask you sometimes who gave this classification. It's the Petersdorf-Beeson classification. Newer classification is also there, which says, okay, FUO can be nosocomial, it can be this and that. We'll just see in a little bit. Let's first focus on the different types. So classical FUO we have just seen. Nosocomial is, of course, what is hospital associated or acquired. Neutropenic, meaning the neutrophils are very, very less in this patient now. Okay, and HIV associated, it is an HIV confirmed HIV infection. So whenever there is 38.3, more than 3 weeks and 3 days or 1 week of intelligent inpatient investigation, it becomes classical. A normal immunocompetent person with all of this becomes a classical FUO. All of this in a person who has been hospitalized in the hospital for more than 2 calendar days becomes your nosocomial FUO. Then a patient with all of these symptoms and neutropenia, less than 500 neutrophil per mm cube of count of neutrophils, becomes a neutropenic FUO, and confirmed HIV infection and all of these, then it becomes a HIV associated FUO. So currently there is this classical nosocomial, neutropenic and HIV associated. The one we have seen in just before all of this if happening in an immunocompetent person, then this becomes your classical FUO. Classical FUO. Was our patient immunocompetent? Yes, we have just seen that we had tried to elicit the history of immunocompromised status and nothing was present in our patient. So we know that he is immunocompetent. Based on all of this, we have been able to show that this is an immunocompetent patient. Great, amazing. Now let's talk about what is an intelligent workup, right? What is an intelligent workup? Physical workup, history, you have included everything. Travel, animal exposure, immunosuppression, drug history, surgery history, diabetes history, all of that you have asked. Physical examination, temporal arteries, splenomegaly, hepatomegaly, organ palpation, everything you have done. Vitals are stable, everything you have done. Okay. Labs, CBC with differential blood counts, you have seen. CBC you have seen, differential WBCs you have seen, everything you have seen. Hepatitis panel, ESR, CRP, CPK, all the inflammatory markers, etc., viral markers, you've all done. Not HIV positive, not hepatitis positive, ESR raised, CRP raised, CBC normal, WBC is normal, everything you have done. This becomes intelligent. Imaging, chest x-ray you have done, and abdominal ultrasonography. Now, abdominal ultrasonography was not done in this patient. There were no associated abdominal symptoms also. They could have gone for it, but they did not go. But chest x-ray came out to be normal. So what have you done? You have taken detailed history, done. Detailed labs, done. Detailed imaging, x-rays, done. Detailed microbiological investigation is also needed. If you do all of this and nothing comes out to be positive, it is only then that we call it an intelligent workup. And it is only then that can we place it under the FUO category. What about microbiology? Urine cultures, done, negative. Blood cultures, not done yet. Okay, so that is what we are missing. Other cultures, sterile body fluids, if clinically indicated, if any other systemic involvement you are seeing. But no such involvement is seen in my patient, so there is no need to, zabardasti take out a pleural tap or a spinal tap or a CSF or something. So what am I missing here? I am missing a blood culture. This blood culture investigation is what will constitute my intelligent microbiological workup. Right. So every time I have such a patient whose chest x-ray, abdominal USG is normal, fever has been there for more than 3 weeks, high grade fever has been there, intelligent CRP, ESR, CBC, everything I've done. Blood cultures becomes very, very important because anyways now we are focusing on to a systemic involvement. A blood stream involvement is what we are looking at. It kind of looks like that. Yes, that is where we are leading. So if we have to talk about the broad categories of FUO, then there can be infections, there can be malignancy, autoimmune diseases and miscellaneous disorders. Since you're sitting in India, the first thing that you have to always rule out in these patients is any kind of infections. any kind of infections. Also, CRP was raised and ESR was raised. It was telling me that there is some kind of a chronic inflammation or infection might be present in this patient. So the most important investigation which is remaining is the blood culture. Now I will do the blood culture of this patient, and I am very, very hopeful since this is India, so blood culture should give me a clue. First, let's look at what all infectious causes can be there, especially in a country like India. TB, of course, tuberculosis. So they had to send a gene expert for this patient. They sent a sputum and a gene expert, sputum for AFB staining and for gene expert, and that came out to be negative. So at least pulmonary tuberculosis is not there. I have still not been able to rule out any other systemic causes of tuberculosis. Enteric fever, which is typhoid. So if I am sending blood culture, salmonella should come out. Then maybe I can do a Vidal test, which can be there. Brucellosis. For this also I need to send blood culture. Infective endocarditis, blood culture. Rickettsial infection, blood culture. So now I am sending blood culture for this patient. 3 sets of blood cultures are to be sent. Why 3 sets? One goes for aerobic, one goes for anaerobic from 3 different sites so as to increase the chances. At least paired. 3 sets is what is ideal. At least paired samples should be sent. Why paired? Because it has been seen that if you send 2 or more blood culture sets, then the yield, the chance of positivity increases from 80% to 90%. So you're really increasing the chances of getting a positive result if you send at least paired 2 or 3 blood culture samples. If it was not an FUO, if it was a fever which was 1 week of history or something, 1 or 2 paired blood cultures were good to go. But since it is a chronic history, it's an FUO, 3 sets of blood cultures are what are recommended. Different venipuncture sites. So, if it's not that you take out the 3 blood culture bottles from the same site, you have to puncture in 3 different sites. So, if the patient is normal, not hospitalized, then 3 different venipuncture sites. If the patient is hospitalized, has any kind of bloodstream catheters, then 2 from peripheral site and 1 from the central catheter site. Okay. So 3 sets from 3 different sites and before starting the antibiotics in this patient. So you know in this patient, antibiotics had not started, he was simply taking antipyretics. If antibiotics have been started, because mostly usually all general practitioners, they will give antibiotics whenever there is a fever, which is a wrong practice even though. But if antibiotics have been started, then they have to be stopped for at least 48 hours. At least 48 hours. You stop all the antibiotics for 48 hours. Then after 48 hours, you collect 3 sets of blood cultures and you send for culture and sensitivity. You know what happened? They all came out to be negative after 7 days. So for full 7 days, the blood culture bottles were incubated in a bactec or an automated machine like we usually do, and they came out to be negative. Now I'm in a fix. That means most of my other cases get ruled out. Why can blood cultures be negative? This is what we have to think. As a normal clinician, we may think that a negative blood culture could mean no infection. But that is not the case. A negative blood culture mostly does not mean no infection. A negative blood culture may mean that there is some fastidious organism which is growing. You know, fastidious organism is the nakrawala people who do not grow easily. So 7 days of 37 degrees Celsius at aerobic temperatures, probably that's not his cup of tea. You need to give the bacteria some special environment, or probably it's a higher end bacteria which will take much more time to grow, many more weeks to grow. Intracellular bacteria, they also take a long time to grow. Prior antibiotics could have affected the yield of bacteria. So that is why we have stopped the antibiotics for 48 hours. What if the bacteria are slow growers? Again, it implies. So negative culture is not equal to no infection. We might be looking at some fungal causes, or we might be looking at some fastidious organisms as the cause. So at this stage, what all do I need to think of? I can think of an intracellular pathogen. I can think of a chronic bacterial infection. What about zoonotic infections? Have I been able to rule out zoonotic infections in this person or not? Yes. So I had asked if there was any history of travel. I had asked if there was any history of immunocompromised state. Did I ask any history of animal contact? No. In India especially, it is very, very important to rule out animal contact history. And most zoonotic infections, especially bacterial infections, they are slow growers, they are fastidious, they are intracellular. So they will not grow on a normal 7-day blood culture. Focus history was taken in the second round, and the person told me that he works in uncle's dairy farm and consumes unpasteurized milk. Now this unpasteurized milk is 2025 NEET PG previous year question. This was asked this year in NEET PG. Unpasteurized milk, the moment you see, you think of two bacteria, Campylobacter or Brucella. Campylobacter will lead to more of a diarrhea symptomatology, which might include dysentery. Also fever might be present. But simply fever present, no associated diarrhea, brucellosis should ring in your mind suddenly. What if the person had given you the history of cat scratches? Then you should have thought of bartonellosis. So all of these zoonotic infections in an undiagnosable fever is what you want to focus on. When the most common typhoid has been ruled out, dengue has been ruled out, tuberculosis has been ruled out, all of that. Great. So Brucella, IgM and IgG ELISA were ordered. They came out to be positive. What is this SAT, standard agglutination test? If you remember the mnemonic, cat sat on a mat with my brother Lee. So SAT is for brother. So SAT is for Brucella. Standard agglutination test, SAT is for Brucella. And we know that any titers more than 1:60 are usually considered positive. In my patient, it was more than 1:640. More than 1:640. This is highly, highly positive. So we have missed out Brucella. So now why did it not grow? We have this cute little flashcard for Brucella always. I always tell you, what do we remember about Brucella or brucellosis? It is Malta fever, also called as Mediterranean fever, because it was identified near the Malta river of the Mediterranean. It was first identified in a soldier over there, and it is caused by the Brucella melitensis. Brucella melitensis, and it is associated with the zoonotic associated with the cows, wherein the species Brucella abortus causes abortions in the cows. So if you get exposed to the pasteurization products, that is post-delivery products, placenta, etc. of cows, you can get infected. If you get exposed to the unpasteurized milk, so who are the people who are at risk? People who drink unpasteurized milk, people who are in animal husbandry, vets, everyone, animal husbandry, vets, people who come in contact with the animals. And of course, how can you forget the lab workers? The lab workers who are always exposed to all the different kinds of pathogens, they are the main people who can be exposed or who will make the cohort of brucellosis infection, right? So Brucella melitensis, and over here in the cows and animals, it can be Brucella abortus, which can cause abortions in these. So if whenever you get a history of a person in animal husbandry who takes care of, babies being born of cows or the dead cows and the carcasses, then you can definitely think of this. There is a clinical classical triad. There is a classical clinical triad which is there, which compromises of the undulating fever and night sweats. There was an evening rise in my patient also. So number one is the undulating fever with the night sweats. So, we say something about brucellosis, and that is that this is a milder type of enteric fever, a milder type of typhoid. In the typhoid, it's going to be a little more severe. A milder format of that is going to be Brucella, where the patient for prolonged periods is going to be troubled by fever, but not as severe as typhoid. Secondly, splenomegaly. And in our patient also there was mild splenomegaly. Splenomegaly is there. And the third part of the classical triad is arthritis or joint involvements. Arthritis, osteoarthritis, joint involvements, joint pains, bone pains. This is the classical triad of the symptoms. Whenever these symptoms come and you have to take the blood cultures, So in the lab diagnosis, it is very important to collect blood cultures and bone marrow aspirate. Both blood culture and bone marrow aspirate are considered to be the best samples for brucellosis. In fact, bone marrow aspirate is also considered to be the most, nice sample for typhoid fever also, enteric fever also, for many systemic mycosis infections also. Okay. ठीक है छोड़ देते हैं. So blood culture and bone marrow aspirate, of course you have to send, and you remember the very special Castaneda's medium, which is the biphasic blood culture. Castaneda's medium, which we use for brucella. Why do we use Castaneda? Because prolonged incubation is needed. In Castaneda, what was the benefit? That we did not have to subculture. We would simply tilt the bottle. This was a biphasic medium, if you remember. In the same bottle, we have the BHI broth and the BHI agar both. So when we have to do subcultures, we tilt the bottle using that. And brucella is a slow grower. It is a facultative intracellular organism or bacteria. It's a slow grower. It takes almost 21 days to grow in blood culture. That is why when I had sent the blood culture of my patient, after 7 days the report came out to be negative. So whenever I have such a patient, I have to make sure that I am asking the lab for prolonged incubation of brucellosis. What is easier to do is serological diagnosis. That is what we did also. So what was the serological diagnosis which was done? Standard agglutination test, which is done most commonly and which we remember with the mnemonic CAT-SAT-ONOMAT with my brother Lee. So SAT is for brother, SAT is for brucella. This is an MCQ. Brucella is a biosafety level 3 category agent. So biosafety 3 category lab should be there. The cultures cannot be opened up like that on normal labs. It is a biosafety category 3 agent. Then another important thing, what is brucella actually? It is a GNV. It's a gram-negative cocobacilli. These are short gram-negative bacilli, bacteria. In the animals, how are we going to diagnose? If you remember, the milk ring test. The pink ring forms in the milk. So you can suspect that the animals are infected. Pink ring test or Rose Bengal card test. Rose Bengal card test. So this finishes my diagnosis and this finishes the entire brucellosis in a single flashcard for you. You can fill it up and you can revise it at any point of time. Recommended treatment is always a combination therapy of doxycycline and rifampicin and prolonged therapy of up to 6 weeks so that relapses cannot happen. Since it's an intracellular bacteria, likes to go and sit inside the cell, complete eradication is very important. That is why combination therapy for prolonged periods is what is recommended in this bacteria. Fever subsided in my patient within 7 days. ESR was also reduced and complete recovery we were able to have in this patient, right? Take home messages is that FUO is a diagnostic approach. History is most powerful tool. Had we elicited the history of dealing with cows working in dairy in the occupational history right at the beginning, or even if we had elicited, had we paid attention to the fact that he used to work in a dairy, we would have thought of exposure to cows and we would have thought of brucellosis, right? Negative cultures don't rule out infection. This is what we need to understand, that even if blood culture, urine culture, everything was negative, we might have deviated onto neoplasms and malignancies and autoimmune panel, and we might have started going for PET scans and CT scans and autoimmune markers using fluorescent flow cytometry, etc. Before going there, we need to stop and think about the clinical history of the patient, and India being a infectious hub. Think zoonotic diseases in India. That is what we tend to miss out. So these are our take-home points from this lecture. And last but not the least, the final approach is that viral fever is a symptom, FUO is a diagnostic approach. It's a diagnosis of approach. Basically, whenever you want to find out the reason of FUO, you cannot jump to conclusions. You cannot jump onto a single diagnosis. How you approach a patient of FUO is what matters, right? And you can never undermine the importance of history taking. Of course, this is where you can reach out to me in case you have any doubts. right? And I always tell you guys to stay in the game. Thank you so much. That was all for today's lecture. I hope you enjoyed it. If you have any queries, do reach out to me on my social media. I will see you again tomorrow in another session of Clinics to Labs, wherein I bring in another interesting mysterious case for your benefit. Until then, it's a bye bye from me. Good night, guys. Thank you.